So welcome back to another edition of the Heart to Heart podcast. And my guest today is Dr. Jay Bhattacharya. I hope I pronounced that right. So Dr. Jay is a professor at the University of Stanford. So Jay, welcome to the show.
Pleasure to be here, Mike.
And so Jay, just before we get going, did you want to list a couple more of your credentials just so people know who we're chatting with today?
Sure. So I'm a professor at the Stanford University School of Medicine. I've been teaching for almost 2 decades here, although I have my MD and my PhD in economics from Stanford. I've been working on infectious disease epidemiology for almost that long as well. I work on health policy issues. Last 2 years, I guess we'll talk about what I've been doing the last 2 years during the podcast.
Yeah, I mean, that's definitely why I wanted to have you on the show, is to mostly talk about COVID. And like I was saying before the show, I think you're one of the few physicians that has kind of taken middle ground in a lot of COVID positions, which is, unusual, unfortunately, in this day and age. A lot of people seem to be very extreme on one or the other. And, that was why, I really wanted to kind of chat with you today. So how did you, first of all, get involved in voicing your opinions about COVID? Why did you start to do that? Because like I had said, I mentioned before the show, there are other professors and physicians who have kind of opted not to say anything, but you were obviously not one of those physicians or professors that opted not to say anything and decided to kind of speak out. So why did you kind of decide to take the position that you have?
So in March of 2020, just like almost everybody else who's in the field, I was looking at the response of COVID in China, in Italy, and I was concerned. I wanted to think through what the right policy response should be, because I do health policy for a living. But I also knew that there were significant scientific uncertainties about the disease. In 2009, I had done work on the H1N1 pandemic. And one thing I noticed then was that this is not my work, but work I noticed at the time was that the death rate that was reported for H1N1, the flu that was the cause of the 2009 epidemic, what was reported was a very high death rate, like 3, 4, 5%, by places like the World Health Organization. But then there were a whole series of studies checking to see how many people in the population had the disease. And it turns out there was lots more people that had the infection than public health knew about. And so the death rate, because the denominator was larger, the death rate was lower than they thought. It was actually 100 infections per identified case back then. And so I thought, well, we don't really know. The World Health Organization in March of 2020 is reporting there's a 3-4% death rate from this disease. The case fatality rate, they called it. But they didn't know that number. They didn't actually know what the true infection fatality rate was, because they didn't know how many people are infected. So I did a study in the early days in April 2020 of this where the idea was, let's measure antibodies in the population at large to see if there's evidence there's many people with infection that are recovered that never came to the attention of public health authorities. That's how I got involved with this. It turned out there was 40 times more infections than cases, 50 times more infections than cases in LA County and Santa Clara County, California, where I live. So I published those studies and found myself in the middle of a maelstrom, which I never anticipated. But that's how I started along the lines.
Okay, so basically in 2009 with the H1N1, you saw that there was inaccurate data reporting. So I guess in March of 2020, when you saw the World Health Organization putting out these numbers, you kind of quickly knew that, hey, we need to kind of slow the brakes on this and maybe look at some other data and make sure what we're putting out is actually accurate. And when you were saying that, I remember, because I was one of those people in March of 2020 where I saw that the CDC put out, and it was on examine.com too, one of the websites I refer to all the time for nutrition and supplements and things like that, because I think they're a very, very good resource. And they indicated that the death rate, I believe at that time, was around 2.5% or somewhere between 2 and 3% for COVID. And so, I initially, like a lot of people, and unfortunately, like many people are still in this position, was very fearful of COVID, and I agreed with, all the measures that were being taken place initially. And then, as the pandemic progressed, more data evolved, and then we found out that the death rate was certainly not anywhere between 2 to 3%. Even in elderly populations. I mean, it's certainly going to be higher in elderly populations than in younger people, but it certainly wasn't that high. So that's why I was in the position that I was, and was saying the things that I was at the time in March of 2020 was because of that data. But that's very, very interesting that you were able to recognize that initially, right off the bat, because of your history with H1N1 in 2009. So really, really interesting point. So just want to ask a few things, Jay, about COVID and what's going on now. And one thing that a lot of people are wondering about now, because there have been some mandates lifted, whereas other regions are keeping mandates in, is do you believe that we should have mask mandates?
I don't think mask mandates serve any particular purpose. The evidence from if you look around the world in places that have very, very high levels of mask wearing because of mandates versus places that don't, there doesn't seem to be very substantial differences. If you try to like carefully control, now you can cherry pick time periods and things where you say, okay, or particular comparison groups and find some effect. But the randomized data from before the pandemic, including many good randomized studies on the efficacy of masks in stopping flu, is that it doesn't work. In order for masks to work, you have to wear them. You have to have a good mask, like an N95 mask. It has to be fitted to you in particular. You can't be touching yourself. I mean, it's for it to work at all. There's certain circumstances that just don't pertain to the population at large. And I think apart from that, the masks have caused massive social division. They become, for many, a symbol of either on one side, a symbol of virtue, because I'm wearing the mask to protect you, or on the other side, a symbol of obedience, blind obedience. It has caused like social conflict and caused distrust in public health. I think the harms from the mask mandates are outweighed by outweigh the potential putative benefits, but I don't really see much evidence that they've stopped the disease from spreading.
Yeah, that's a really good point, because a lot of people, always say, well, surgeons wear masks and things like that. But it's like, yes, but they're all actually in, a sterile environment in the OR when they're doing that. They have, a sterile gown on. And, one of the first things you learn when you're going through, medical school is, once you put on that gown, you don't touch your face. I did it once, my very first rotation. I was doing OB. I think we're doing a C-section. I did it by accident, and then
I was very, out of the room, and you go wash up again.
Yeah, and it's the biggest pain. I mean, it takes at least 10 minutes or 15 minutes, when to get all the gowns and stuff back on. So, it's kind of silly to compare, wearing a mask in a sterile environment in an OR compared to, someone, taking a mask that's been in their, glove box for, 6 months, and then they just take it out every time they need to, go into a store. Like that's not the same thing. So, we're not saying that masks don't work. That's not what we're saying at all. We're just saying that the comparison of, from wearing a surgical mask in the OR to wearing them in the community is not a fair comparison whatsoever. And like you said too, I do think that with regards to masking, like there is some one-way protection, meaning that like if you have a mask on, particularly an N95 mask, there may be some evidence that can be protective, but in terms of making everyone else wear a mask to protect each other, I just don't think that's a viable strategy, or a strategy that's really going to reduce infection or disease overall. So I think that we should do away with the mask mandates as well, and hopefully people in the future understand that and make those and implement that particular policy, because I do think that, like you said, like there are a lot of harms to wearing the mask, particularly for young children, and we don't know what the consequences of those are going to be. I mean, we know some. Actually, I think you probably familiar with, there was a study that came out, maybe it was 2 or 3 months ago now, that showed that children that are born during the pandemic are having lower IQs, and really just not behaving appropriately for their age, not developing well. And you can't help but think that's because of masking, because we learn to understand body language more than phonetic language, or sorry, before phonetic language. So we need to understand body language, and if kids aren't able to recognize faces and see faces, then they're actually not learning that very, very important language at a critical developmental stage. Like we know it's important to talk and to communicate, and people would be up in arms, or would be very, very concerned if children obviously just stop communicating verbally. But in terms of communicating through body language, I think that's actually just as important. And unfortunately, a lot of kids are going to miss out on developing those critical body language skills during a very important developmental stage of their lives.
I think we'll be able to see. So, like the U.S. CDC recommended masking toddlers as young as 2, whereas other places, in the World Health Organization says don't mask any kids from 2 to 5. The European CDC recommended no masking under the age of 12. So this is a very, very different. If the science was settled, then why are these scientific organizations coming with such different recommendations?
Yeah.
And I think in coming years we'll be able to see what the consequences are by comparing what effect the masking had on children as young as 2 in the U.S. versus like in the UK, that no masking. No, we certainly didn't ask masking toddlers. So we'll start to learn. I think this is one of those things where, like, normally you would ask for randomized studies, right? We're going to make this extraordinary recommendation of masking toddlers. Show us a randomized study with evidence that it actually works. You would never, of course, run a randomized study trying to see if there's harm, because I mean, that would be unethical, right?
Yeah, very unethical.
You would never have organized a randomized study looking for masking, on the effects of masking toddlers before the pandemic, because it doesn't pass there's no equipoise there. And I think we're in a situation where public health recommended absolutely extraordinary measures without the evidence base to justify it in so many ways, and certainly masking toddlers fits that.
Yeah, and just before we move on from masking, I mean, all these people who claim to be evidence-based physicians, they're recommending something without there actually being any evidence for it, which is kind of hypocritical in a way, in my opinion. So one thing, of course, I wanted to ask about today was vaccines, and I do believe that they have saved many lives and people who are vulnerable to the disease. But I'm not sure if the best approach is to double vax everybody and to boost everybody all the time. And I'm just kind of wondering, in one particular age category, there's a couple that I want to ask you about, but one is myocarditis for boys or adults between the age of 16 to 24 years old. Like, there's some controversy about whether or not you would be more likely to get myocarditis from the disease itself, COVID, or from the vaccine. And from the data that you've analyzed, Jay, do you feel that males between 16 to 24 should be getting vaccinated, maybe just with one dose from Pfizer that seems to be less damaging, or sorry, it causes less myocarditis than Moderna? Or do you feel that it should be a case-by-case thing? Or what is your opinion on vaccinating boys between the age of 16 to 24?
So first, on the question of myocarditis, like, my read of the literature is that somewhere between the vaccine causes myocarditis in young men at the rate of somewhere between 1 in 2,000 to 1 in 10,000. So there's some controversy in literature on pinning that number down, but that's a pretty high rate. The right question isn't the myocarditis caused by the vaccine versus myocarditis caused by COVID, because COVID can definitely cause myocarditis also. The right question is if the vaccine doesn't stop you from getting infected. It just doesn't. It doesn't stop you from getting infected. So the right question is, if you get the vaccine and you get COVID, what's that joint risk of myocarditis versus the risk of myocarditis from COVID alone without the vaccine? That I haven't seen a ton of work on, or careful work on. My sense is that you're probably going to get the risk of myocarditis from the vaccine and also from COVID, maybe slightly lower from COVID if you have the vaccine on board, versus just COVID alone, where it's a close call. It probably is the case. I mean, if I had to pin a guess, I'd say it's for that age 16 to 24 range. It's higher if you have the vaccine and COVID versus just COVID alone with myocarditis risk. But I think the literature is still in flux on that.
Okay.
I think as far as like the recommendation, I'd say, I think it absolutely has to be a case-by-case basis, right? So a child who has immunocompromised or has other particular health conditions, the vaccine is probably the right idea. A child or a young adult who's relatively healthy, they're very likely to suffer like a mild disease if they do get COVID. I mean, it's a perfectly reasonable choice to say no, I think. And certainly like a booster in that age range, I just don't see the benefit. The marginal benefit is low and there's potential harm. The right way to handle that is to advise people to go talk with their physicians and see if it's right for them.
Okay. So yeah, so overall, it should be more of like a case by case basis as opposed to just sort of like mass vaccination for everybody, so to speak. For people below the age of 18, would you say it should be case by case, or when do you feel it should be more, say, mass vaccination versus case by case?
Well, I believe the vaccine should be offered to large numbers of people. So in that sense, I'm in favor of mass vaccination, but I don't think it should be coerced. I think it always should be, in the context of this vaccine anyways, a private decision. I'll tell you why. Right. So with vaccines that are in common use in the population, like the measles vaccine, for instance, it has both private and public properties. Private meaning that if you vaccinate your child with the measles vaccine, they're protected from measles. Right. If they get the measles, no longer poses quite a threat to them if they're exposed to it. If at the same time there's public benefits, so the kid who's vaccinated with the measles vaccine will not spread measles to other people. So it both protects the kid that's vaccinated and others, protects you and me, right?
Okay.
This vaccine, the COVID vaccine, does not have that same property to the same extent. The vaccine has a private benefit in reducing the harm if you get COVID. It reduces the likelihood of dying from COVID. It reduces the likelihood of being hospitalized from COVID. But it does not have, to the same extent, the public benefit. You can still get COVID and still transmit it. People who are COVID recovered without the vaccine actually are probably less likely to get COVID and less likely to transmit it than someone who's just bare vaccinated.
Okay. Yeah. So they're not taking in natural immunity into that, or acquired immunity, however you want to.
Yeah. So like what that means is that you have a vaccine that provides a private benefit, but not very substantial public benefit. The argument for mandating it, forcing everyone to get it, with the idea that that's how we're going to stop the disease from spreading, doesn't apply, right? It doesn't have any force, because the vaccine itself doesn't have that property that we look for in traditional vaccines of stopping the disease from spreading. So the argument for mandate is much weaker in the context of the COVID vaccine than it is in the context of measles vaccine, for instance.
Understood. So when you get measles, it is going to prevent the spread of measles to someone else, or prevent infection. Whereas if you get the COVID vaccine, then it's unlikely to. But Jay, in the first 10 weeks or so after you get the vaccine, does it prevent spread or infection then when your antibodies are high, or is there no window of period where you get the vaccine?
No. So it's complicated. So the first 2 weeks after you're vaccinated, you're actually more likely to get infected.
Okay.
But then infection protection rises and peaks around, I'd say, 3 months. Like the number varies in literature, but let's say 60-70% efficacy against infection at 3 months, and then it plummets, so that by 4, 5, 6 months, the efficacy is like 20%. And some studies are saying like 0%. So by just a few months after you're vaccinated, the protection against infection goes away. On the other hand, the protection against severe disease seems to last for quite a long time, right? So you're now the first 2 weeks, we should have been telling people, first 2 weeks, really do isolate yourself after you're vaccinated, because you're more likely to get infected.
That's very interesting. And what would be the roughly the rate, Jay, of like how more likely are you to get infected during the first 2 weeks after you get back?
I mean, it would depend. It depends on like how much community spread there is and so on. Of course, it's hard to answer that question with a single number. I mean, I think it's negative vaccine efficacy against infection during those first 2 weeks. If you look at a lot of the studies that analyze it, they'll exclude the first 2 weeks after vaccination or count them as unvaccinated.
Yeah, that's what they do. That's what they do. They say that you're not vaccinated until 2 weeks after.
Yeah. So, but if that's true, then what should have happened is a recommendation to go with the vaccine. Say, look, be really careful in the first 2 weeks after you're vaccinated.
Yeah, and that, I mean, this is, news to me. I mean, I didn't know that you were more likely to, be infected with COVID for the first 2 weeks after the vaccine. I'm kind of a little bit embarrassed.
I don't think it's like a guarantee, obviously, but it's just a curious fact. The vaccine takes a couple of weeks to start to kick in to create the protection against infection.
And then
short-lived.
And in terms of vaccine selection, so my understanding, correct me if I'm wrong, Jay, is that the Moderna vaccine has about 100 micrograms of the mRNA in it, whereas the Pfizer has about 30 micrograms of the mRNA in it. So because of that, that may be the reason why we're seeing a little bit more myocarditis with the Moderna than versus the Pfizer, although I hear that the second Pfizer shot is also similar rates of myocarditis as Moderna.
So I don't have to look up the exact doses, but I think the key thing is to understand about like we're talking about rates of one for young adults, young adult men is 1 in 2,000 to 1 in 10,000.
It's still very, very low.
Yeah, so most of the young adults in that age range won't get myocarditis from the vaccine. But the key thing here is that the vaccine is an mRNA vaccine. The dose that you get of the mRNA is not the same thing as the dose that you get of the antigen produced by the mRNA. That depends on how much of the antigen, the spike antigens, are produced by your cells by the mRNA. And that's very variable, actually. Like some people produce a lot and some people produce less in response to the same mRNA dose. So you don't know for certain. I don't think we have any way of predicting in advance if you're going to get that myocarditis response. I think part of it has to do with like, does the spike protein stay where it's supposed to stay, or does it go into your heart? What kind of inflammation does it cause there? Does it, there's all kinds of like things that go into that are not particularly well understood. It's certainly not something you can predict in advance before you take the vaccine.
Okay, and then one last question too about mixing the vaccines, because I heard Peter Attia say fairly recently that in terms of how the mRNA vaccines work versus the non-mRNA, is that the mRNA vaccines are more likely to boost your antibodies, whereas a lot of the non-mRNA vaccines are more likely to boost your T cells. So he was kind of thinking that, if he had 2 shots of the mRNA vaccine, which I believe he did, he was thinking that if he was going to get a booster, and I'm not sure if Peter decided to get a booster or not, that he would maybe consider getting a non-mRNA vaccine, because then he would kind of get the best of both worlds. Just wondering if you heard anything about this and what your thoughts are on that.
I mean, the evidence seems to be that mRNA vaccines also create, sort of T cell immunity and other cellular immunity also.
Okay.
I haven't seen any evidence to me to suggest that like a categorical difference in the sort of the more traditional vaccines response versus the mRNA response. I will say this, that most people who are vaccinated, a very large number of people who are vaccinated have also got infected, certainly through the Omicron wave. So in a
Definitely.
sense, they've had the booster, right?
Right.
The Omicron infection effectively counts like a booster, I would say. As does the so I got the Pfizer vaccine in April of 2021, and then I got Delta infection in August of 2021, right? So I mean, I think that kind of hybrid immunity is pretty strong. Of course, there's no guarantees in life, but it seems like that if you're going to think about boosters, you should also account for whether you have infected and recovered in the meantime. Hopefully, like people hearing this understand. I'm not against it, but I think it should be a choice based on your personal health circumstances that you discuss with your physician very carefully about whether it makes sense, and you balance the potential benefits with the potential harms. The potential benefits, I think, are much higher. For instance, for older people, if they get infected, have such a high risk of disease, bad outcomes, that if the vaccines and boosters protect against that, then that's a benefit you weigh against the potential harms, and you say, okay, it comes out much easy. For younger people, it's much closer.
Yeah, I think that's sort of the issue, is that everyone's sort of like looking for like a blanket response. You should get vaccinated if you have this. You should not get vaccinated if you don't have this or do have this. Whereas overall, it seems like it should almost always be more or less an individual decision. And as you get older and as the comorbidities add up, I mean, it's going to be very, very likely that getting 2 doses of the vaccine and potentially even a booster if you didn't acquire Omicron or something after would be beneficial for you. But I think the issue is people are sort of looking for just like the quick answer, and also too, it's much easier to say, okay, we're just going to vaccinate everybody, as opposed to like, hey, go to your doctor, get assessed, see what he or her thinks about it, and then make your decision based upon that between the conversation that you guys have. That's a lot more tedious and difficult, as opposed to just saying, hey, everyone get vaccinated.
But that it's much more ethical too, right? So we have this like obligation for informed consent. We don't give people medicines that they don't need necessarily. It should be a personal. And I'm not saying that you should never have a vaccine, just like we talked about just a little while ago, for whom nearly everyone needs to be vaccinated, right? That there are vaccines, I believe, that are like that. But I just don't think the COVID vaccine is one of those vaccines.
Yeah, that makes total sense. Well, thanks so much for answering all my questions on vaccines. That was super helpful. So just want to move on a little bit to treatment. So, March of 2020, it's a lot different than, we're almost in March 2022 right now. It's a lot different. We do have some medicines that do seem to have some type of, efficacy and that do work. The one that I guess hasn't really been, initiated yet in terms of the general public that seems to have the best data is the Pfizer drug Paxlovid. And the study that I saw on that, I'm sure it's the same one that you saw, it said that reduced hospitalizations, I think, up to 90% or something like that. And then in the adverse event group, there was actually more adverse events in the placebo group and more people who discontinued the drug in the placebo group than actually in the control group, which, to me shows that the drug is extremely safe and efficacious, overall. But again, that's just one study, and we know what Pfizer did say about their vaccine initially, which, again, we're not saying that it doesn't provide protection, but it certainly didn't provide the protection that we initially thought it would. So, I'm interpreting that data with caution, but I am, still excited about it and interested in looking at the data. So just what are your overall thoughts are on Paxlovid?
It looks really promising to me. I mean, we're going to have to see how it works out in the real world. Yeah, I'm much higher on Paxlovid than I am on the Merck drug, which the Merck drug seems to have, like, it has a mechanism of action, essentially a substitution of a nucleotide, that I just don't. It makes me nervous. That mechanism of action, frankly. Whereas like this one, the mechanism seems to be immune modulation, which it strikes me as the right pathophysiologically, the right kind of approach to this.
Okay. Interesting. Yeah. I didn't know too much actually about the Merck drug. I saw there was a little bit of, media play on it maybe a few months ago, but I haven't really followed up on the data about that since. So I'm glad that you commented on that. One drug too that seems to be getting a little bit of play now that's kind of interesting is Bucylamine, and it's interesting to me anyway because it has a mechanism of action that's similar to NAC or N-acetylcysteine, and I think N-acetylcysteine is a fantastic supplement for a lot of different things, and for people who aren't familiar with it, it's used in emergency rooms, but it's also used, but by people in their everyday life. It can help treat certain psychiatric disorders. It has benefits that are good for both your liver and kidneys. So, a lot of good things about that drug. And the reason why I bring it up is because they say that Bucylamine as a file donor is 16 times more so than NAC. So I'm just wondering if you have researched Bucylamine at all and have any thoughts on that particular drug.
I don't know much about that drug. I'm sorry. I shouldn't probably give comments on a drug I don't know much about.
Okay, no, safe to say. I just wanted to ask you about that quickly, and then the big one too that a lot of people, are still inquiring about, and is ivermectin. And then for me on that drug, I'm certainly open to that drug being effective, potentially prophylactically, potentially early on in treatment. I don't know if it's effective later in treatment. That being said, I did see the Cochrane review, which came out last summer, that indicated that it basically didn't have the efficacy to recommend treatment. And then I believe there was another review done sometime in the fall, or maybe early on in the winter, that also indicated that it wasn't efficacious overall. So, what are your thoughts overall on ivermectin?
I don't know if it works or it doesn't work. I've seen two competing reasonable meta-analyses, actually. One concludes that based on a whole bunch of randomized trials, it works, and the second one on the very similar set of randomized trials, overlapping set of randomized trials, concluding it doesn't work.
Yeah.
Of course, there's a JAMA study that was just recently published that, again, with a weird result, which is that it seemed to not work to prevent hospitalizations, but did work to prevent deaths. None of this is statistically significant. The thing was out of Brazil. There's a big study that the NIH has funded called Active-6 that is due to be complete in March of 2023 on ivermectin, on bucenamide, and fluvoxamine, I think, is the third one. And it's weird that we're still 2 years in the pandemic. We don't have consensus on this. We have a lot of fight, but not consensus. And I don't really understand why. This is, we produced the vaccine so quickly and tested them so quickly. We got consensus pretty quickly. We should have had a similar effort for all these cheap repurposed drugs as well.
Yeah, it is really, really odd that we don't have a definitive answer on it. And I'm not sure if you saw this, Jay. I put it on my Twitter recently. I'm just going to kind of read it out just because it was very strange to me. So this is what I wrote, and I can link the study for people in the podcast notes after. But I said the authors in this study conclude that ivermectin should not be used for COVID, but the ivermectin group required less mechanical ventilation. And there was 4 people versus 10 people, so that's 1.7% versus 4%. Fewer ICU admissions, so 6 people versus 8 people, so 2.4% versus 3.2%. And then had fewer deaths 3 people versus 10 people, and that's 1.2% versus 4.0%. So, they're saying that it's not effective, but if you really look at the data in the study, I mean, to me, like, it would be almost like, if this data is true, it'd almost be like unethical not to give the drug. I
Yeah, I
mean,
mean,
why
it's
would you?
those by conventional measure. I think we're talking about the same study that study
Yeah,
from JAMA. I think it was Brazil, right? Like that study, it's such a curious result. Like the bottom
yeah,
line,
JAMA study.
you shouldn't
Sorry, go
use
ahead.
it.
Yeah,
You shouldn't use it. But then, if you look at the most severe outcomes, it seemed protective. None of which was statistically significant. I think this is one of these things where what you need is a consensus based on a large definitive study that should have been run already. Why have we not run and reported this large definitive study? Why, like, how is it okay that the National Institute of Health has funded a study that's due to be done in March 2023 for these drugs? 3 years late. I mean, we should have had this done by March of 2021. Not
yeah.
2023. And I think this is like, so more broadly than just simply which things work, although that's certainly very important. The response of the public health community to this has been to sort of delegitimize early treatment altogether.
Mhm.
There are people who've been arguing for early treatment from almost the very beginning, that have been essentially cast out, put in the fringe as if somehow the very thought of early treatment is heresy. Monoclonal antibodies are a good example of this, right? So those are there's I don't believe
Yes.
there's any controversy at all that certain formulations of monoclonal antibodies can work, especially if given early.
And sorry, Jay, just not to interrupt you, but is that from the literature I've seen, the monoclonal antibodies are extremely effective against the Delta variant, but are they effective against Omicron?
There is one, I forget the name of it, that seems like it's effective against Omicron also.
Okay.
Some of the ones that were effective against Delta are not so effective against Omicron.
Okay.
Um,
Okay.
but just take the Delta. So when Ron DeSantis argued, like essentially created infusion centers, sent people, the strike forces to go to people's homes if they got COVID. Older people got COVID to infuse monoclonal antibodies. This was seen as like a scandal to provide early treatment to people. This should have been done universally. We should have
Yeah.
ramped this up, because the evidence against Delta was like 70% reduction of hospitalization if given in the first few days. Why did this turn into be something controversial? It should have been like universally copied. And I don't, I actually posted something on Twitter about this. I joined Twitter in September of 2021, after years of telling my students not to join, but hopefully they forgive me for that, but I couldn't resist. But I posted something on this and I got pushback about that. Why am I encouraging people to get monoclonal antibodies? And the thought seemed to be that if there's early treatment, that decreases demand for the vaccine. I think that's a mistake. Like, why not tell people, here's the range of things you can do that'll help? You shouldn't be like policing, like trying to like manipulate people into behavior by saying, oh no, if you get the disease, it's going to be really bad. There's no way to treat it. Therefore, you should go get the vaccine. You should say, look, there's a vaccine that works really well against severe disease. You should get it. And if you happen to get sick, there's this early treatment. You should get it. I mean, I think we should provide patients with all of the range of options based on what the evidence has shown, and not try to like manipulate how they act to try to get them to do what we want them to do.
Yeah. No,
Preventing.
I agree. I think that was very deceptive and very manipulative of them. Like, I think what they did was that, they withheld information because they felt that, if people knew that, hey, if you take this monoclonal antibody, it's going to reduce your hospitalization by 70%, then the person would say, oh, I'm not going to get my vaccine because, if I get if I get COVID, then I'm just going to take these monoclonal antibodies and I'll be fine anyway, which is ridiculous, because what you should do is, get the vaccine to protect yourself. And then if you do get a breakthrough infection or do get sick, then you use the monoclonal antibodies, on top of it. I mean, why not use, all the tools in the toolbox? Like, why are we using only this one tool? And then assuming that, if you do get the vaccine, that you're not going, that if you don't get the vaccine, if you if you believe in the monoclonal antibodies, that you're not get the vaccine. And I think that's completely ridiculous. And I don't think most people have that opinion. Like, I don't think that most people would, not get vaccinated if they knew that there was another treatment out there to treat them if they get infected. I mean, surely there may be some people that may decrease the vaccination rates slightly, but I don't think that that overall that strategy is effective.
Well, even if it does, like the question is like informed consent, right? So somebody who thinks I'd rather risk the monoclonals, COVID and monoclonals rather than the vaccine. I mean, I would try to convince them, especially if they're older or otherwise, but if I fail, I want them to get the monoclonals because I don't want them to die, right? I think there's this like sense of like, we're gods and we're trying to like make the people do what we want. We're not. What we are as servants. Like, we are people who are offering people options based on what the evidence is showing, and that's it. That's the best we should be hoping for. And I think, actually, ironically, I think we probably would get more uptake of the vaccines if we were more honest about what was possible. Like, a lot of people who are not skeptical about the vaccines is because they don't trust public health anymore.
I agree. And the other worry about that for me is that, like you said, there are vaccines that, that most people should get, right? And my fear now is that because, we've pushed the COVID vaccine, narrative too hard, that it's kind of deterred some people from vaccines in general, and that they actually may not get vaccines in the future that they should be getting. So I do think that, the public health messaging has really, during the whole pandemic, has really been misconstrued, and also it's going to create unfavorable conditions and policies in the futures. And I think that the distrust from the people in the community is just going to keep rising and rising. And unfortunately, that may cause some people in the future to not get a vaccine that they actually should, just because they have a general distrust in public health. Whereas if they were just, very, very truthful from the start, then I think people, wouldn't have that mindset going forward.
Yeah, I completely agree. You're already seeing some evidence of this, right? So the trust in public health regarding the childhood vaccines is actually decreased quite a bit compared to what it once was. You have the movement against vaccines, which was once a fringe movement, I mean, truly a fringe movement, is now become a more mainstream than I could ever have imagined. And worldwide, the number of childhood vaccinations has actually collapsed. Like, it really shrunk sharply. We're going to be seeing the consequences for a long time, because it's not just that the kids that didn't get vaccinated. It's also that the collapse in public health, trust in public health, will have these ripple effects, and it'll show itself up in many ways that'll harm the health of the public in coming years.
Yeah, it's going to take a lot of effort to repair that, for sure. Another thing that I wanted to chat with you about too is just sort of general lifestyle and supplements. So, the one that I've seen the most data on by far seems to be vitamin D. I think people are starting to call me Dr. Vitamin D now, just because I've tweeted about it so much. And, I don't want to say like definitively that it absolutely, works for COVID, but all of the studies, like study after study, has shown that, it does seem to decrease your risk of severe disease. So I'm not sure if you've been, researching the literature on vitamin D, but, do you think this was kind of another thing that they failed to discuss in public health? And do you think that,
I have been tracking that literature. It looks incredibly promising to me, actually. And I'll say this, like, in medicine, you'll always consider that any medication you give somebody, your supplement you give somebody, whatever, you have to consider both the harms and the benefits. Like, there's no unmixed medicine, I believe, and there's always going to be some possibility. But I think on vitamin D, the possibility of harm for someone who's vitamin D sufficient, especially getting a supplement, I think is very, very small. Whereas the benefit, I don't know that it's proven, but it's really, really promising, the evidence, in terms of like what reaction you'll get to COVID if your vitamin D is sufficient versus vitamin D insufficient. So why wouldn't you recommend it to the population at large? And that includes not just vitamin D by supplement, but vitamin D by going outside and getting
Sunshine.
sunlight. I
Yeah.
mean, that's really good for you, even apart from the vitamin D, I think. Those kinds of like recommendations toward a healthy lifestyle should have been done from the whole pandemic. Instead, we like said, stay home, stay safe, don't go outside. I mean, like in Australia, they limited the number of hours of exercise. You could only get 1 hour of exercise outside time during their sharpest lockdowns.
Crazy.
I just don't understand it. I mean, it seems like bad public health. There's an opportunity to tell people about what health might look like more broadly than just COVID, when people's minds were so focused on it, and we threw it away.
Yeah, I mean, what you want to do, and I mean, all of medicine in medical school is always like a risk benefit, analysis. And I mean, the thing is with vitamin D is like you should be taking it anyway. I mean, especially people living in Canada, we definitely don't get enough vitamin D, particularly right now in the winter. It's February, it's like -10 out. So, you basically just run into your car and come back in as
Like you
fast
should
as you
convert to
can.
California.
Yeah, yeah, I'd love to move to California. So, I mean, I think that that's another thing that's failed in public health, and just coming back to like the risk benefit thing. Like, you should be taking it anyway. Like, low vitamin D is actually linked to depression. Low vitamin D is linked to low testosterone. So these are important other clinical parameters that you can fix, and issues that you can fix by taking your vitamin D. So you should be taking it anyway. And again, like, there's basically no downside to having optimal vitamin D. It's only going to help you. So, why this wasn't discussed, to me is a complete mystery. And, I don't know why it
Well,
wasn't.
I think it's of the same thing, right? So, like, I don't think vitamin D is a cure or preventive. Like, it won't prevent you from getting COVID. I do think there's some evidence that it modifies the disease to make it milder if you are infected. I think a lot of people in public health viewed messaging around that as dangerous,
Mhm.
because that means people won't stay home and stay safe. That means people won't take the vaccine. That means people won't comply with these NPI measures, these non-pharmaceutical intervention measures, as enthusiastically. I
Yeah.
think a lot of the pathology around how we've talked about these kinds of interventions, like vitamin D, like the monoclonal antibodies, it stems from the same root. This idea in public health that we can't give people these tools for fear that it'll make them not comply with the other interventions that we're doing.
Yeah, and it's strange too how the other big one too. It's not a supplement, just something you can do is reduce your weight, because it looks like obesity is severely linked to severe disease. And there's people like yourself and other doctors who are discussing it, but it's not really discussed that much in like the mainstream media and legacy media. And I think that we could have said that messaging a lot earlier. And I understand, like, I had another guest on the podcast recently. We both said, like, obviously you're not going to lose a bunch of weight overnight, but the thing is that this disease has been around for 2 years, right? So you can lose a lot of weight and you can change a lot to your health in just a few months. I mean, 2 years is a very long time. And again, it's something that you should be doing anyway. Again, if you lose weight, you're going to probably control your blood sugar better. You're going to feel better. You're going to have more energy. You're going to have a better sense of well-being overall, likely. So, again, like, something that's, very low hanging fruit, not we're saying that it's easy to lose weight, but it is, a simple intervention that you absolutely can implement, immediately. Anybody can start losing weight right away whenever they want to. So I'm not sure, again, why that wasn't, messaged from public health officials in the community.
I mean, I think part of the pathology about how public health messaging is this idea that everyone is equally at risk from COVID. That
Mhm.
no matter who you are, you have effectively the same risk. But that's still a lie, right? So age, for instance, is the single most important risk factor. Obesity certainly is a risk factor, increasing your risk by by double probably for someone who's like sort of normal weight versus morbidly obese. Diabetes, I mean, a few things like that, right? So why not tell people to make changes in their lifestyle that will reduce their risk? Well, I mean, that's good for me. That's good medicine. It's good public health. But like some people in public health wanted to maintain this illusion that we're all equally at risk. And so if you say there's some modifiable risk factors, well, now you shattered that illusion.
Yeah, exactly. You know, once you shatter that illusion, then it kind of shatters some of their messaging in some ways. And it seems to me that you know, a lot of people in public health, you know, Dr. Fauci, whoever it is, they don't want to say that they were wrong. You know, they don't want to say that, you know, hey guys, we put out some messaging that, you know, is not very accurate, and you know, we want to make up for that. And, you know, we probably should have been telling you about vitamin D, and probably should have been telling you to lose weight a long time ago, but, you know, we didn't. And unfortunately, I just think that, you know, there's too many egos involved, and people just don't want to get that messaging, you know, out there. And another thing that I think happens in medicine too is that, you know, I'm an MD, but I do like to talk about nutrition, and I do like to talk about supplements. And I think that in as an MD, you're sort of taught in some way to kind of stay away from those types of interventions. And you're also kind of taught to, and you should be, but to be very, very wary of, you know, a naturopath or someone who's maybe not as credentialed as an MD, and that anything that they're saying is more or less, you know, quackery, when in reality, you know, evidence is going to determine whether or not something works. And I think that it's a mistake in medicine and by MDs who kind of dismiss any type of lifestyle interventions or any type of supplementation that may in fact be beneficial. Because if you're an MD and you talk about vitamin D and you talk about obesity, as ridiculous as it sounds, there are physicians out there who are going to call you a quack just for discussing those items. And they're going to call you a quack because, you know, they're not medical pharmaceutical interventions or vaccine interventions that are going to help, you know, reduce COVID. And I think that that's something that we need to, you know, fix in the medical community as MDs, is that we need to collaborate with other people. And of course, there's always going to be, you know, quacks out there who are promoting, you know, some kind of crazy supplement that has no evidence for it. But there are going to be some, you know, alternative healthcare practitioners that are evidence-based and that are putting out, you know, good, high quality information on things that can make a difference, like vitamin D and like obesity. So I think we do need to make a little bit of a correction in that in our community there.
Dismiss people or dismiss ideas or dismiss possibilities just because of credentials, right? As you say, Mike, I think the right thing is let's look at the evidence. Let's develop good evidence. I think there is a history of people pushing, you know, miracle cures that don't have a lot of evidence behind them, but that's not the same thing as saying that there's not like vitamin D is a good example of this. I mean, I'm looking at the evidence. It looks really promising. Do I know for a fact? I don't believe that that's the standard where I say it has the same level of evidence as you know, the measles vaccine or something. But like, but it has pretty good evidence, especially in the time of where there's a lot of uncertainty about what to do. You have to rely on like what evidence is there, and if you have naturopaths or whoever it is citing evidence and engaging in arguments based on standards of evidence, why would you dismiss somebody like that? That doesn't make any sense. So we should, and I think part of the issue though is also that you know, if you have a drug or a product or a supplement, whatever it is, that's not on patent, you don't have a very strong, you don't have any entity with a strong financial incentive to evaluate it.
Right.
You have a drug like Paxlovid that we talked about. You have Pfizer has a very strong, it's on patent. If it turns out to work, Pfizer's going to make a lot of money. They have a very strong incentive to like evaluate it, to run a big convincing trial to make sure that everyone knows that it works if it works. You get something like vitamin D. No one owns vitamin D. No one's going to have a patent on it. And so you don't have an entity with a strong interest in evaluating it to run that big definitive study. And so you're always going to have with these drugs, with these supplements that don't have an owner, this controversy, because no one has the incentive to run the study that would like clear up the controversy.
Yeah.
It's actually I think, a perfect role for government. It's like that's why there's government supportive science. Government supportive science should be on these evaluating these things that where there is no private interest in doing the evaluation, but that look promising. It's another area where I think the scientific agencies have failed us. Right, instead of like doing evaluations, open-minded evaluations, rapid ones, with the same kind of alacrity as Pfizer had with the vaccine, which was good actually. It's not a bad thing. We should have the public health agencies like the National Institute of Health rapidly in the U.S. rapidly doing assessments of these with the same level of energy of these cheap drugs that no one has an interest outside in the private sector of evaluating. That's what's good for health.
Yeah, I agree. We need to hold, these medicines to or the supplements, to the same standard as pharmaceuticals, and, give them, the same amount of funding so that we know, which ones work and which ones don't. And I am going to ask you one more question, because I know we don't have too much time left. But just before I do, I just want to make one comment that I did see recently too, that curcumin has been shown to be potentially as an effective aid for COVID. And there was actually a meta-analysis, I believe it was in hospitalizations. I put it on my Twitter. I think there were 6 studies that were maybe involved in that study, and it did show that there was some efficacy. So kind of interesting. But my last question I have for you is, so do you think that we should just end lockdowns altogether right now? Do you think that we should basically just go living back to normal life, or do you think that there is some value in keeping some restrictions in place?
I think we should end lockdowns altogether. I think this has essentially become we've reorganized social life around these restrictions, around the fear of COVID, and I don't think they've accomplished much. I mean, there was a recent Hopkins meta-analysis looking at the effect of the severe strict lockdowns, shelter-in-place orders on mortality. I found no effect. The reorganization of our social life around the control of a single disease has negative health consequences in and of itself. Now, that said, the disease is here forever. It's here to stay. And I think there are still vulnerable people, older people. They're still, I mean, less so in Canada, more in the United States. You still have vulnerable people who have not been vaccinated, who have not had the disease yet. Certainly a lot of folks like that around the world. We should work to vaccinate them. We should work to develop resources to help protect them. And we should continue to develop better vaccines, better treatments, continue to do the normal scientific things we do to try to get to try to better treat this disease. But we should manage the disease the way we manage the 200 other infectious diseases that are in common human circulation, rather than making the central focus of all social life.
Yeah, I think we just, need to learn to live with it. And, it's not 2 years ago. We understand the disease now. We have several treatments that work. We have a vaccine that works, and we know what to do. And I think, it's time to kind of move on and just start, living with this. So Jay, that being said, we're kind of all out of time there now, unfortunately, but you answered so many questions that I had today. So really, really appreciate you coming on. Thank you so much. Can you tell people where they can find you on Twitter and where they can find you online?
Sure. My Twitter handle is Dr. J, just the capital J, Bhattacharya, Bhattacharya. Every third letter's an A. I publish my work in lots of different places, but Twitter is probably the best place to find me nowadays.
Okay, awesome. Well, thank you so much again for coming on, Jay. Really appreciate our conversation, and we'll have to do it again sometime soon.
Yep. Thank you, Mike. Pleasure to talk with you.